Welcome, our next speaker, Anna Gadignani. I'm going to read a very brief introduction. Anna is a PhD student in health science, technology, and management. Her background is in philosophy and history of science. She obtained both her bachelor's and master's degrees from the Alma Mater Studiorum, University of Bologna. Sorry, no, it's okay. I saw a little hand, but I'm going to continue. During her master's, she studied bioethics and ethics of artificial intelligence at Macquarie University at Sydney, Australia. Her research has primarily focused on the doctor-patient relationship using an interdisciplinary approach that encompasses political and legal philosophy, care ethics and virtues, and the social history of medicine. Her current work examines how to rethink the principle of autonomy in healthcare. And the title of her talk is Reconstructing Trust, Social Historical Trajectories of the Physician-Patient Relationship in Post-Unification Italy. So welcome, Anna, and the floor is yours.
Thank you so much also for the introduction, and thank you all for being here. So I'll try to share my screen in order to present you better the topic of my talk today. So why reconstructing trust? So this is a talk that I'm delivering after my master thesis. So this is the topic that I cover over my master thesis, and it has shaped a lot the question that I am addressing right now during my PhD pathways. So I would like to begin from the point of origin of this research, which stems from an interest in the history of science and specifically in the social history of science. So my initial intention was to explore how material cultures, practices, and beliefs shape scientific knowledge, and to understand how science itself is constructed as a social phenomenon and not merely as a body of theories. So my main reference was Piero Camporesi, an Italian cultural historian who explored how everyday practices like eating, healing, and caring for the body reflected the moral and imaginative worlds of early modern Italy. I'm sorry that the references are Italian, but you can find his work translated in English as well. After that, I became interested in other scholars who explore similar questions, but from a feminist perspective. So looking at how knowledge and care were shaped in gendered relationship, especially the work of Catherine Park and Gianna Pomata. So through her study, I also came to know the work of Sandra Cavallo, that show how spaces traditionally considered private, such as the home, the family, and the body, are in fact sites where medical knowledge is produced, transmitted, and negotiated. And her perspective makes visible a network of informal expertise, affective labor, and moral responsibility that rarely enters into the official narratives of science or medicine. So in this sense, her work resonates a lot with the work of another Italian scholar, Carlo Ginzburg, and his peculiar focus on microhistory, where the attention to the minute, the marginal, and the everyday practices reveal underlying structures of power and meaning. So both forms of knowledge and authority are embedded in the material and relational texture of ordinary life, dimensions that the traditional history of ideas often lives in the shadows. So at the same time, I realized that I lack a specific object of inquiry. I did not want to focus solely on a particular form of caregiving, not merely studying a professional figure. Both would have offered interesting insights, but neither was sufficient to explore the deeper moral and relational dimensions embedded in care. So what I was looking for was a vantage point that could bring together knowledge and relationship, practice, and morality. So alongside my historical research, my philosophical work drew me to a complex and multifaceted concept, trust. So here, feminist philosophy again was particularly illuminating, emphasizing how moral obligation, interdependence, and relational responsibilities arise in caregiving context, a dimension of human interaction that abstract ethical theories often overlook. In moral philosophy and moral psychology, especially Annette Bayer has been especially influential. So she framed trust as a moral practice where the trustee acts for the good of the one who relies on them. And her insight inspired further research, including Mark Alfano and Karen Jones' work on trustworthiness, which explore how ethical commitment intersects with competence in both social and epistemic settings. So from this perspective, trust emerged as a multidimensional phenomenon, bringing moral, relational, and epistemic concern. A distinction that I found particularly useful is that between trust, which involves a moral commitment to the well-being of another, and reliability, which concern competencies or effectiveness in performing a task, regardless of intention. So this framework naturally led me to one object of study that connected my historical and philosophical interests. So the relationship of trust between doctor and patient. So the question I decided to pursue is the following, as you can see from the street. But in other words, the question could be framed in other terms. So in the sense of, can we understand how the moral dimension of care relationships has taken shape over time, not only by analyzing ethical theories or texts, but by also observing the practices, the institutions, the gestures, and form of interaction that gave concrete form to that trust. So from the outset, I encountered two major methodological difficulties. The first one was to avoid anachronism, namely projecting contemporary moral categories into historical contexts that did not share them. So to address this, I focus on a period relatively close to us, yet historically well-defined, the Kingdom of Italy, a time where public health became a systematic object of state policy and medical care entered into the discourse of biopolitics and public control. And the second difficulty is concerned the primary sources. Initially, I considered analyzing correspondence between doctors and patients. However, I realized soon that such sources reflected a literate world, unrepresentative of the Italian society as a whole. So to remain consistent with a social history of care, I choose instead to focus on a long marginalized but crucial figure, namely the medico condotto, or public health officer, the public doctor appointed to assist rural or subaltern populations. And two principal considerations guided this focus. First, there was a logic of proximity, namely that the medici condotti were professionals who cultivated enduring relationships across diverse population segments, but particularly among those with limited means. So this profound interconnection with individuals and their family elevated them to figures of substantial social and cultural importance that help to at least draw a conscious collective to their category. And secondly, the Medici Condotti played a pivotal role in shaping national institutions in Italy. Their social standing rose steadily following the unification due to the augmented authority and political relevance conferred by the first national governments. So, following from the relevant secondary literature, I consulted the archives of the Archiginnasio of Bologna, which is one of the most important archival institutions in Italy. And through the Frate Sorbelli catalog, I identified materials belonging to two main categories. First, the medical etiquette manuals, or Galatei Medici, text on conduct and professional morality, representing an informal but widespread ethical reflection. And second, legal sources essential for understanding the institutional creation of the figure of the medico condotto and the development of the national healthcare system in Italy. So, the first phases of my research brought me into contact with the direct voices of the Medici Condotti, particularly to polemical pamphlets, which you can see on the left side of the screen, short public writings through which physicians voiced professional grievances, debated ethics, and defended their role, and documents of the Associazione Nazionale dei Medici Condotti, established in 1874. The association, which one document you can find on the right of the screen, was created with the explicit aim of promoting professional regulation, uniting practitioners, and strengthening relationship within the specific branch of the medical profession. So it is noteworthy that the legitimacies of these associative efforts was grounded in practical attempts to protect medical practice, not only in terms of treatment, but also in terms of professional interaction. So, as numerous testimony underscore, the practice of medicine was inherently characterized by benevolence and charity, oriented towards safeguarding the health of individuals. And in this sense, the virtue of medical practice lies primarily in the performance of care itself, rather than in mere adherence to abstract moral principle. Therefore, the formation of a professional association becomes essential. It functions as a collective body seeking recognition and support for governmental institutions, ensuring that the protection of the practice was granted. So the Associazione Nazionale dei Medici Condotti thus represents not only a step towards professional consolidation, but also an acknowledgement of the authority and legitimacy of the medico condotto. So from these sources, two major issues emerge, both in defining both the professional identity and their relationship to trust. First, there was a lack of institutional recognition. So the Medici Condotti complain about the precariousness of their status, their dependence on local administration, and their inadequate pay. This gave rise to a genuine professional consciousness, a collective demand to be recognized as an integral part of the state and public health apparatus, as we can see previously regarding the Associazione Nazionale dei Medici Condotti. But then there was also a lack in popular recognition, namely that the Medici Condotti also had content with popular medical traditions and non-official forms of healing. So from this tension emerged a complex negotiation of trust. Doctors needed to earn authority and legitimacy in communities that did not automatically granted it. So comments and practices aimed at gaining trust as well as undermining it were often directed at countering the influence of alternative therapeutic figures. So on one hand, physicians sometimes express negative opinions towards these practices, and on the other, their positive impact and effectiveness within local communities were undeniable. And here you can see on the left part of the screens two of the main sources that I used to trace these pamphlets against the alternative therapeutic figures called as charlatans. So the same sources that I used to trace the grievances of the Medici Condotti, therefore offer a rare glimpse into perspectives often overlooked in historical records, those of families, patients, and sometimes even alternative practitioners themselves. The medical profession frequently emphasizes the population ignorance and its consequent distrust of physicians. Yet this perception largely reflects a lack of communication and understanding between different knowledge systems. So some physicians sought to educate local population as a means of social progress and reconciliation, but there is a little evidence of reciprocal engagement from the communities towards the medical class. So two key elements help outline the real state of care of post-unification Italy and illustrate the absence of influence and resulting distrust towards institutional medical knowledge. First, the complaints of the Medici Condotti highlights both the practical difficulties of providing care across large and often hard-to-reach territories and the challenges in communicating with local population. And second, the proliferation of medical publication advising physicians on the proper moral conduct towards patients reflects a broader reflection on the physician-population relationship, underscoring the central role of trust and moral perception in the acceptance of institutional medicine. Thus, while structural deficiency linked to economic backwards and political choices limited the development of a comprehensive national health system, a growing interest in fostering effective physician-patient interactions emerged from the class of the Medici Condotti themselves. So this interest can be interpreted as an effort to assert a monopoly over the therapeutic relationship. And a particularly revealing case concerns especially women's care, encompassing both care for women and care provided by women. So medical paternalism and misogyny shaped trust along hierarchies of gender and knowledge. So female bodies were widely perceived as physically, intellectually, and morally more fragile, which prompted physicians to adopt cautious and distant approaches. Admonition advocating caution in treating women often accompany broader tendencies to trivialize female illness, generating significant limitation in effective medical care, especially during pregnancies, childbirth, and the postpartum period. So faced with male reluctance or lack of competence, women increasingly relied on alternative therapeutic figures, including relatives, midwives, practical workers, and traditional alternative healers. So particularly midwives were not merely substitutes, but essential actors in healthcare, bringing together the institutional medical knowledge and the rural population. So they represented the traditional knowledge within the scientific framework, helping the medico condotto mediates when entering into the local population. So they both together shared professional expertise and the community who saw them as an integral to local social and care networks. Nonetheless, in the 1910 parliamentary debates that covered the topic of recognizing institutional recognition to Medici Condotti, the midwives were excluded, and due to their less authority, which was not kindly supported by the Medici Condotti themselves. So At this stage, trust clearly emerged as a key instrument through which Medici Condotti asserted both their institutional and professional legitimacy. It was not merely a relational virtue, but a strategic practices that allowed physicians to establish authority within communities, navigate tension with alternative therapeutic figures, and educate population about institutional medical knowledge. An especially interesting aspect emerged from the comparison between the medico condotto and the priest, who represented the principal moral and spiritual authority in rural 19th century Italy. So the temporal authority of the papal state, coupled with the widespread establishment of its institution, reinforced the Christian Catholic faith across the peninsula. Especially after the Counter-Reformation in the 17th century, the priest functioned as a local representative of papal temporal power, interpreting the Holy Scripture, guiding the faithful, and acting as the primary intermediary with the people. So the intertwining of church-state structures with the fragmented realities of duchies, kingdoms, and provinces consolidate areas of influence for population control. The metaphor of medicine priesthood then must therefore be seen as an outcome of the historical intertwining of medical science on one hand and Catholicism on one other, especially in Italy. So while the gradual secularization of political and social structures reduce religious control over healthcare, the ethical overlap between medical and religious institutions persisted, particularly in terms of moral values and virtues guiding therapeutic actions. In practice, the relationship between priests and Medici Condotti was not strictly oppositional, but a nuanced alliance, variable according to local needs. So various contributions, and here you can see the major one on the right, il parroco istruito nella medicina, offer insights into rural realities and exemplify this dynamic. The virtuous conduct expected of Medici Condotti align closely with priestly teachings. So despite divergent epistemic approaches, the underlying morality of their action, compassion, benevolence, and responsibility was largely shared. So from this perspective, 19th century medical etiquette can be understood as an instrument to consolidate professional authority, while echoing some of the priestly moral value. Etiquette emphasized the physician's responsibility and linking social standing and professional legitimacy to both competence and ethical commitment. It also marked a gradual shift away from purely Christian charity toward a professional ethic in which moral virtues became codified as standard practice. In Italy, this development positioned medical etiquette as the initial manifestation of an ethical framework collectively embraced by the profession, which both guided conduct and reinforced trust between physicians and the communities they served. A key element in understanding the physician-patient relationship in 19th century Italy is professional secrecy then, which emerged by analogy with the confessional seal, yet with important distinction. While confession concerned the individual penitent, medical secrecy extended to the family, reflecting the physician's duty to navigate not only individual care, but the broader social and familial context. Decision about whether to disclose the truth to a patient often required family consent, revealing that trust was built not solely between doctor and patient, but within a complex network of familiar and communal relationship, a model that continues nowadays to influence Italian medical practice. it is crucial to emphasize that confidentiality was the primary ethical principle championed by Italian medical etiquette. Physicians were expected to keep all information obtained during practice strictly confidential, both for its therapeutic value and to maintain social credibility as well. So the rigorous adherence to privacy was closely linked to the religion Catholic tradition of caring for the soul, borrowing metaphors and moral authorities from the confessionals. Just as the priest safeguarded the penitent's secrets to maintain spiritual cohesion and community trust, the physician protected patients' information to uphold moral and professional authority. So professional secrecy extends beyond moral symbolism, and Italian medical etiquette emphasized continuous engagement with the patient family, integrating them into the treatment processes, especially in the depictions of the anamnesis, the initial investigation of the patient condition. The dependence on the family participation and the physician trust in the information provided by relatives was central to perform an effective care. So medical etiquettes also emphasize the therapeutic value of hope, especially for patients nearing the end of life. Physicians were advised to maintain trust with both patients and family, carefully balancing honesty with reassurance to preserve confidence in their judgment. Collaboration with priests during the administration of the extreme unction reflected a shared ethical concern for the patient's spiritual and physical well-being, further reinforcing the intertwining of moral, religious, and medical authority. Ultimately, Italian medical etiquette portrayed trust as a multifaceted therapeutic process. So it encompasses not only technical proficiency, but also ethical conduct, moral distraction, and collective approach to care involving family and community. So a trustworthy physician was one who mediated effectively between medical expertise, family knowledge, and spiritual concern, establishing credibility and authority while enhancing the therapeutic alliance. In this way, confidentiality, professional ethics, and relational care were inseparable, forming the foundation of both the physician's legitimacy and the social acceptance of medical practice in 19th and early 20th century in Italy. So, in conclusion, my initial question provided not fruitful but transformative knowledge. It highlighted aspects of Italian bioethical culture that have often remained at the margins. The role of everyday practices, the communal dimension of care, and the historical contingency of moral values. So, historical and cultural research shows that trust that does not arise solely from ethical principles or individual virtue, but from social norms and relational dynamics that shape the individual and their community. While modern rational medicine since the 19th century has demystified the therapeutic action, it has often overlooked this essential rule, trust, namely. So present-day Italian codes of medical ethics emphasize mutual trust through instruments like informed consent, yet they rarely reflect on its ethical and moral significance, which is deeply rooted in cultural and historical practices. So reflecting on the physician-patient relationship historically suggests that a renewed medicine could recognize shared responsibility and intention, ensuring that care is a reciprocal ethical practice. This requires a meticulous and nuanced exploration of social, cultural, and moral trends, a complexity that although here I exemplified in Italy, I think it could offer useful insights for other nations and communities as well. So for me personally, this research has shaped my identity as a clinical bioethicist. It confirmed that bioethics cannot be limited to normative analysis, but must interrogate practices, cultural dynamics, and the trust relationship that give meaning to medical action. So I thank you all for your attention, and please ask question or share your insight. Thank you.
Oh, thank you, Anna, for your wonderful talk.
Thank you.
I really like it. So now we have some minutes for questions. You can raise your hand. Yes, Kirsten.
Yeah, thanks. That was a really fascinating talk. I was curious about whether whether you learned anything about the role of consent in all of this. So, I think trust is, I think you very convincingly showed us how trust works here. But yeah, but consent. Can you tell us anything about that?
Well, actually, there were no reflection about consent, namely that the action performed by the physician to the patients was kindly not just recommended, but it was like on the part of the patients and on the part of the family, like to continue the suggestions or the care practices offered by the physician. So I think that what can be like really interesting in that sense is the fact that towards all the kinds of recognitions and grievances and the idea of separate the professional figure from the more benevolent one that were like embedded in the Catholic institutions. The idea of remuneration and the idea of like giving and pay the physician an adequate amount was like really driving all the major reflection, especially within the Associazione Nazionale dei Medici Condotti. And so the idea that the first obligation of the patient was to pay the physician, and that's really interesting because consent on that side was like perceived as, so you called me, you're paying me, therefore you are following me. If that answer your question.
Yeah, so I take it the idea is if you trust me, you don't need I don't need your consent because
Exactly.
yeah, okay.
Exactly.
Yeah. Well, I have a question, if I may. There's drilling also here, so I hope you don't listen to us. So I have a question about archives
Mm-hmm.
and um, and how archives or your work related to this research and in the archives can be generalized to other cases in the history of science or bioethics. I'm thinking, for example, in obstetric violence, because you were also addressing these issues.
Mm-hmm.
So I was wondering if you reached, I mean, you talk a little bit at the end, if you reach a conclusion about this relation between archives, history, and bioethics. I don't know. a
Yeah, no.
philosophical inquiry. I'm sorry, it's kind of
No. I answer your question based on the idea that I have about I'll try to answer, and then if I do not answer, please ask me again. So, regarding the triangulation of how the use of archive can be useful to illuminate those kinds of black holes in the reflection. So especially for midwives, I found very, 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 very little. And the majority of my reflections came from analogies with the French situation, especially because the class of obstetrics were built thanks to the Napoleon Reformation. So most of the reflection concerning of obstetrics in France can be applied to a certain extension to the Italian case. But again, the sources regarding Medici Condotti are very, very little, and basically concern the sources that I showed you, and those are in form of pamphlets. And they are not widely shared through our peninsula. So I was really, really lucky to find them in the Archiginnasio of Bologna, because I think that it's maybe the only one, if not the second, archive in which you can find those kinds of sources. And I think that another difficulties with respect of trying to draw inferences on cultural and traditional practices is the fact that the practices themselves are practices. So therefore, it's really hard to find written works that emphasize directly that kind of practice. So even in the case of the medical etiquette, I think that they are really fascinating, not because they provide what was the moral codes or the ethical reflection of that time, but they rather reflects a way to engage in peculiar situation and trying to find solutions, which is sometimes that not really reflects how things were performed. I don't know if I answer your question.
Totally. Yes. Thank you. Thank you, Anna. Demian?
Yes, thank you. Can you hear me?
Yes.
Thank you. Well, thanks for the talk. I just have a question about these last values like hope and then if they were taught in the schools or if any chance they were incorporated in the academy. I mean, like the universities or the schools of medicine or something like that. Just that.
I do not understand who should be
if like when you talk like hope as a value that they were practicing in the medicine, if that value like hope were teaching in the schools, like me as a professor were like, yeah, you should feel the hope with the patient or something like that.
Well, that's a really great question, because still nowadays in Italy, we do not have like a proper instruction in the medical courses regarding ethics or bioethics. And that comes from the idea that actually it pertains to the physicians itself, so like to the professor of clinics, to provide some suggestions to the students to how they have to behave properly with their own patients. So there was not a direct instructions. So even in the medical text, there was nothing that can be related to instruction to moral philosophy or something similar. Especially in the post-unification Italy. So the students of medicine only study medicine, biology, physics, which is very close to the kinds of studies that I have to perform even nowadays. And the suggestions were given only by the head of the chair of clinical practice. So, but that was again something that became peculiar really at the end of the 18th century and only in certain institutions. So, for example, in Bologna, there was this preeminent scholar called Augusto Murri, who in his own lecture appointed some reflection that were across like philosophical domain, not only regarding the same practice of inferencing and like use causality or correlation from symptoms to make the diagnosis, but also in terms of like really moral reflection to how cultivate the diverse perspective of the family. But no, regarding to your question, no.